Hello. Hi, it's Kathy Frey here from IMCO, and welcome to this week's Maternity Natural Health webinar. And we're welcoming Carolyn today. Say hello.
Hi.
And we're just needing people to sign on in here, and yeah, that is fantastic. So Carolyn Ledowsky is in Australia, and so it's a little bit early in the morning for her at the moment. But yeah, well, that's just fantastic to have you here. And while you're all just signing on in, just a reminder, if you could please go into the chat section and do let us know your role and whereabouts you are in the world. That would be fantastic. And remember that down the bottom of the screen is that section where the Q&As are. So if you've got any questions for Carolyn today, just put them on in there and we'll absolutely make sure that we get them covered. And we've got an absolutely fascinating topic today, which is all about miscarriage, and talking particularly about mother or MTHFR, which Carolyn Ledowsky is going to go into some good detail on. And just to give you a little bit of background, Carolyn is the founder of the MTHFR Support Australia. She's a naturopath, she's a herbalist, nutritionist, and has a Bachelor, of course, in Herbal Medicine as well, and a Bachelor of Naturopathy and Advanced Naturopathy, and also did studies at Duke University, which is in the USA. So yeah, so you have to tell us a little bit more about yourself today, and let's just have a little look how we're going with our people coming in. Oh yeah, that looks great. So we've got a couple of chats coming in. It's so great to have you all here. And somebody from England, wonderful. And we don't often get you guys because I think the timing's a bit late in your day, but it's neat to have everybody here. So yeah, so welcome, Carolyn. And why do women miscarry? What about women who are concerned about their personal or their family history of miscarriage, and what key genetic susceptibilities contribute to an increased miscarriage risk is what we're going to be talking about today. So shortly, Carolyn's going to take over. She's going to do about a half-an-hour presentation, including a PowerPoint slide show, and then we'll come back and do Q&As at the end particularly. So welcome, Carolyn. Take it over.
Thank you, Kathy. All right, let me share my screen. I'll put it into presentation mode and we'll be ready to roll. All right, thanks everyone for joining me today. I think Kathy did a good job of my intro. I guess my specialty is definitely the fertility side of my business. I think, you know, it's every woman's right to be able to fall pregnant, and I really think that there are many things that we can do to stop the rate of miscarriage. And I think because you're all practitioners in this field, this is something that I think should be absolutely top of mind. Every time you see someone who's come in with a history of miscarriage or a family history of miscarriage, I want you to be thinking about MTHFR, and I'm going to explain why today. Now, it might be a little bit longer than 35 minutes, but I will do my best. All right, so our mission is to reduce the number of miscarriages worldwide. And obviously I can't see all the women in the world as much as I'd like to. I think it's my job to teach what we do in our clinic to other practitioners around the world, because we've just got to get people to understand that if they're thinking about preconception or pregnancy, they really should be checking for the MTHFR gene. 25% of all pregnancies end in miscarriage. That's a hell of a lot of people. And it's on the increase. And 15% of couples, or that's 70 million couples worldwide, are affected with infertility. And half of these undergo IVF. So the normal route now is they go and see their GP, say, well, I'm having problems falling pregnant. they then refer them on to a fertility specialist, and the next thing we know, they're going down the IVF route. Problem is, 70% of these fail. It's a pretty poor success rate. And from the research that I've been doing, I also think that we're not giving babies the best opportunity through IVF, because you can't possibly replicate what happens in nature. And it's this methylation tags that get put on immediately after conception that we've got to be most worried about. So let's talk about folate for a moment and put this into perspective. So as I'm sure you all know, there's different forms of folate. So folic acid is our synthetic form of folate. It can't be metabolized by the body unless it is converted to many different aspects, and I'll show you that in a minute. Folinic acid is an active form, but it's 5-methyl tetrahydrofolate that is the biologically active form. That's what our folate cycle is meant to create. So as we said, folic acid is a potential issue, because what we're seeing now is that almost everybody who comes from a country of fortification has a level of unmetabolized folic acid, which means the folic acid isn't being converted to 5-methyl, it builds up, and we call that unmetabolized folic acid. Now, there's been some research done on unmetabolized folic acid in regard to natural killer cells, cancer, what else? There's been a lot. So prostate cancer, breast cancer, bowel cancer, but they just are, as yet, it's not, we just don't know the actual results of what this means. Is it a problem? Is unmetabolized folic acid a problem? Biologically, we know it is a potential problem, and I'll show you what that means. But this is a really good example of a research study that was done looking at the high dose folic acid supplementation. So I'm sure that, you know, I don't remember who it was, but maybe it was Karen that was from the UK. You know, when someone goes into a infertility clinic and a specialist fertility clinic, the first thing they do is usually get prescribed a 5-milligram dose of folic acid, particularly if they've got MTHFR polymorphisms. And this was a study with men that looked at, excuse me, the 5 milligrams of folic acid. And it says these findings, contrary to expectations, high-dose folic acid supplementation resulted in a global loss of methylation across the sperm epigenome. And it happened with everybody, but it was more prominent in those with MTHFR. So I think this standard protocol, and we're going to talk about this because you are the lucky ones. This is going to be the first time I've ever shared with you the research from my thesis, which I literally put in yesterday for marking. So it's pretty amazing for me to be able to present that. Folic acid, we know that as calcium folinate. It is metabolically active, but it is not the biologically active form. Now, this is our folate pathway. Don't let it scare you off, but essentially what it means is that this all happens inside the cell, and there are 2 receptors here and a transport carrier that brings folate into the cell. Now, folic acid comes in, but it's this enzyme dihydrofolate reductase that we're most concerned about, because it is the one that converts folic acid to our important tetrahydrofolate. But it's slow, and it really doesn't cope with a lot of folic acid. So before fortification, it probably wasn't a big deal if someone was taking a supplement, because the research says that, you know, maybe about 200 micrograms gets through of folic acid a day. But with fortification and with people taking folic acid-based supplements, this enzyme is getting saturated, which means we get this buildup of unmetabolized folic acid. So it's not going anywhere. It's building up in the blood, but we're not getting this folate being shunted down to, importantly, tetrahydrofolate. And then all the way down the bottom, what we need to make is 5-methyl tetrahydrofolate. That's the form of folate that goes on to supply SAMe with its methyl donor that then goes on for methylation of DNA. So it becomes a really critical thing that we're able to look at these genetics and say, because here's folinic. So even though folinic is active, it still has to be converted by the MTHFR enzyme to methyl folate. So where folic acid is at the top, we want to be creating this. So particularly with someone with an MTHFR polymorphism, we don't want to be giving folic acid because they've got to go all the way down here and they still get a block here. Same with folinic, I think. And from my fertility patients, I know that a lot of them have homozygous polymorphisms in this MTHFS, which breaks down folinic. So that becomes an added issue. And I think we've got to be striving to give them methyl folate where we can. So it's affected by the MTHFR gene. It's a biologically active form. It's methyl folate that we want. Okay. And I thought I'd give you a case history. This is one of my patients. I've changed her name, but she was 36 years of age. She had had multiple miscarriages when she came to see me, and they were pretty well all before 12 weeks of gestation, mostly via IVF. And look, you know, she had done what you would expect everybody that wanted to fall pregnant would do. She had seen naturopaths, she had seen natural fertility specialists, she'd seen IVF specialists. She was falling pregnant okay, but she just couldn't keep the babies. And I think when I saw her, she'd had 3 or 4 miscarriages. Her husband was also on multiple formulas. And so I lined them all up. There was about 35 different supplements they were both taking a day. And I said, all right, I pushed them all to the side. And I said, okay, I just want you to start with these 3 things. And they went, oh my God, I can't believe I'm still taking that. So the key was, though, when I looked at her genetics, I actually gave her 10 times the amount of folate that she was on. She went into IVF, but she said to me, I'm going to use my old eggs stored. Now, I don't see any point in doing that because the whole advantage of spending 4 to 6 months in preconception care is you're affecting the health of every single egg. So I don't get why you would use old eggs, but she did. And unsurprisingly, she miscarried again. But I wasn't upset at all. And I sat her down and I said, this is actually a good thing because I want you to use your good, healthy eggs. And so she did, and no IVF, she fell pregnant straight away. And she had a little boy, there's little baby Jack, and she has gone on to have a daughter, no IVF, no specialist clinic. She just came back to us, said, I want to have another one. And she did. And she's now in the process of getting ready for baby number 3. So that's a very typical case of what we see. And that's just her thank you to say, you know, and she calls the methyl folate her happy tablets, because not only did it change her ability to fall pregnant and stay pregnant, but it actually completely changed her mood and her personality. She became a lot more confident person. She became a lot happier. She became a lot more sure of what she wanted and how she wanted to do it. So that was really nice to see. So when we look at patients like this, it's really important to understand what is their ability naturally to make folate. And you can see there that she was heterozygous for C677T, MTHFR. She was also heterozygous for the MTHFD1. And if you remember on that folate pathway, it's one of those trienzymes that really shunts that folate down the folate pathway. She was homozygous for MTHFS. So again, that's very typical that we see that. So folinic is definitely not the answer. And the folate receptor 2 that pulls that folate into the cell, she was heterozygous for that. And so understanding someone's genetic susceptibility is really key. And what that looks like when you plot it out, you can see where I've circled all these. That's where she had the problem. So can we stand back and say, hey, Jenny has a really big problem here in making her folate in the first place. So what do we need to do to help Jenny get that methyl folate and make SAMe for her particularly her methylation of her DNA methyltransferases. So incredibly important. And you can see here purines, and this is our amino acids again for purine synthesis. Well, she's not going to do that particularly well because she's really got a big problem in this pathway. So when we look at the key issues that women have, it could be hormonal imbalances, it could be the fact that they're not ovulating, low healthy cervical fluid, endometrium not healthy, not enough follicles, multiple miscarriages. And I hate to say it, but the ability of someone to make methyl folate is going to affect all of these things. And so this is really key. So genes, their genetic susceptibility is absolutely the number one thing that we look at. The lack of folate or the lack of the right form of folate, the lack of preparation time. So, the more reading I get, the more I'm convinced that, we've got to be looking at that 4 to 6 month time frame. And we've really got to be counseling women on the correct nutrition. I'm sure we're all really good at that. But one of the things we have to acknowledge is that those with MTHFR polymorphisms do have a bigger issue with detoxification. So even assessing buildup of toxins is key. So when we say that a lack of folate is really linked to all of this, then we know then how important our methyl folate is and the ability to be able to make that. The research that I've found on, particularly with men, I mean, some men go on to have oligozoospermia, and some are producing absolutely no sperm at all. And MTHFR polymorphisms have been associated. So again, it's just not good enough to be looking at the woman. We have got to be assessing whether or not the male has genetic polymorphisms as well. So again, we know that there's a huge demand of healthy DNA during pregnancy because of the intense growth of the fetus. So this is something that we've really got to be able to focus on. So for those of you that don't know a lot about MTHFR, and I'd love you to put into the chat box whether this is a brand new concept to you or whether or not you're familiar with it, and that's one of the reasons why you're here. But MTHFR stands for methylene tetrahydrofolate reductase. It's basically a fancy word for an enzyme that converts the folate we eat into active 5-methyl tetrahydrofolate. So I'll refer to 5-methyl tetrahydrofolate as methyl folate from now on. And so the MTHFR, as you saw in that previous folate pathway graphic, is that it is the last step. And some people, if they have polymorphisms, you can have a 70% downregulation. So if you're homozygous, which means you've got 2 copies of that gene that are mutated, you could have a 70% downregulation in your ability to make methyl folate. So that's a significant amount. That's not something that we're talking about 2 or 3%, 70%. And if the male has the polymorphism as well, then that becomes, quite a big issue. So what does the methyl group do that the methyl folate makes? Well, think of it like an on-off switch. It's the ability of the body to take that methyl group, connect with it and say, okay, now I can do my job. So anything that is a methyl transferase has to have SAMe donate that methyl group for it to work. So our ability to methylate our DNA, our ability to make creatine, our ability to detoxify, our ability to break down toxic estrogen, our ability to make neurotransmitters all rely on a methyl transferase. Our ability to break histamine down relies on a methyl group. And so my personal theory is that this wrong form of folate that we're using is actually affecting our ability to create methyl folate, and that is affecting all these methyl transferases that just don't have the ability to work. And unfortunately, you know, in Australia, we have one of the highest rates of asthma in the world, and I think this is part of the issue. So when we look at the research and we say, all right, what does a downregulation in methylation affect? And this is just some of the things, they're not all the things. You can see how wide-ranging these issues may be for someone. And, you know, we see people with these issues every single day in our clinic. So as I said, definitely MTHFR variants will affect male fertility. We can see a lower sperm count or no sperm count, a higher DNA fragmentation, which means we've got really bad, crappy DNA, reduced motility of sperm, which, as you know, that's not going to help us at all, and greater infertility. And this is such a good graphic because this is an example. If we took dad and mum, so here's dad, here's mum, and we say, all right, you've both got one copy of the MTHFR gene from your mum or your dad. So your baby or their baby has then a 25 or 1 in 4 chance of being homozygous for the MTHFR mutation. So the babies that are homozygous are the ones that are more susceptible to miscarriage if mum or dad didn't have the right form or the right amount of folate. If we left mum as being heterozygous, but we changed dad to homozygous, all of a sudden, every second child will be homozygous. So that chance of miscarriage really increases exponentially. So just to take you through a bit of the research, if we look at some of these studies, this was a study that looked at maternal, fetal, and paternal MTHFR polymorphisms and the risk of recurrent pregnancy loss. And it says, in summary, the results of our meta-analysis indicate that maternal and paternal MTHFR polymorphisms are associated with recurrent pregnancy loss. This one looked at the risk of cleft lip and cleft palate in those with MTHFR polymorphisms. And it says children carrying the homozygous variant, which we just talked about, may have an increased risk of cleft lip. The risk associated with this allele was obviously higher when mothers didn't take, well, they say folic acid, but again, in the research, all folate is called folic acid. Unfortunately, you've got to delve in to find out whether it was folic acid or methyl folate. This one looked at folic acid supplementation and IVF and basically said high folic acid intake and MTHFR gene variations seem not to be associated with helping women to achieve pregnancy. Well, yes, because they're using the wrong form of folate. Here we looked at recurrent spontaneous abortions in those with MTHFR, and we noticed a high frequency of MTHFR, specifically with the T allele. So that's the homozygous allele with the father's side. Therefore, the present study indicated the impact of paternal gene polymorphisms with recurrent pregnancy loss. So even if mum has no MTHFR polymorphisms, she can still miscarry if her partner has an MTHFR polymorphism. This one looked at Down syndrome and said that MTHFR was affected or predisposed someone to trisomy 21. And I think, again, because you're getting this disturbance in DNA methylation, you can easily get issues with trisomy. MTHFR is associated with ovarian follicular activity. So it says here that it's associated with a higher FSH level and may be a determinant of response to ovarian stimulation. So again, we've got to look at what is going on when we we take someone through IVF. So this is what I'm really excited. It's not published, but it hopefully will be. And so my study was looking at, do practitioners who test for MTHFR genetic polymorphisms in infertility patients use different forms and dosages of dietary and supplemental folate? So it was a case series. It was a retrospective case series, and we looked at the pregnancy outcomes in patients who were seeing their practitioners who had infertility and MTHFR genetic polymorphisms. We had a look at all the MTHFR genetic polymorphisms that they had, and then we documented the different dosages and forms of folate that the practitioners were prescribing. And so the results. So we had 6 practitioners submitted 12 cases. We reported on, probably best to show you this summary. So here's the 12 cases. We a variety of different years from 36 to 40, 41 to 45 years. And you can see that all of them had been diagnosed with infertility coming into this. All of them had MTHFR polymorphisms, and all of them, bar one, had had multiple miscarriages. This poor lady had had 10 miscarriages coming into this. You can see that the practitioners prescribed mostly just methyl folate. They actively told their patients to remove folic acid from food. 75% told them to remove it from food, and 100% removed it from the supplements that they were taking. And of the 12, 11 fell pregnant, 1 miscarried, and we had 10 live births, which is pretty amazing given that they had all been trying unsuccessfully and had been diagnosed with infertility. So if we have a look at it, of the 12 cases, they all had MTHFR. 1 was homozygous for the C677T. 5 were heterozygous. There were no homozygous A1298C. 2 were heterozygous, and 4 were compound heterozygous, which means they had 1 MTHFR C677T and 1 A1298C polymorphism. And you can see that there was 16% with the A1298C, but by far and away, the C677T was the highest with a 41.7%. And it's dropped off here, but the compound heterozygous were 33.3% of the group. And so when we looked at the form of folate, so 2 of the patients coming in to their first appointment with their practitioner were actually on the high dose folic acid, 5,000 micrograms. They were both taken off it, and both of them managed to fall pregnant, admittedly with IVF, but they did fall pregnant. As we said, folic acid was removed in supplemental form, and 75% were advised to avoid or be mindful of food fortified with folic acid. And the 5-methyl, all patients were prescribed 5-methyl at varying doses, and some were prescribed folinic and methyl. So the mean amount of methyl folate that the practitioners prescribed to each of these women was 2,325 micrograms a day. That's far and above the recommended by policy of 500 micrograms of folic acid. So you can see that doses much higher were being used to successfully get these women pregnant. Folinic acid, the average, only 5 patients were given a combination, and the amount of folinic acid was 670 micrograms on average. And as I said, the patients that were given that had the previous failed IVF were given 5,000 micrograms of folic acid. That was taken away from them. They were then prescribed 5-methyl, told to avoid dietary folic acid, and successfully fell pregnant with IVF. And so you can see here on the left-hand side, this is the methyl folate amounts that each patient was prescribed. These were the folinic acid. On the left-hand side, you can see the dosages. So what's quite interesting here is that obviously the lowest doses were given to the A1298C because that's the one that has the least effect, like maybe a 20% down regulation. But the average that was given to those with a heterozygous polymorphism was actually 2,800 micrograms. But you can see that the one lady who fell pregnant but miscarried twice, she was actually on the lowest amount. She was not anywhere near the norm of 2,800 micrograms prescribed. She was only given 500 micrograms. So I think that was a really interesting phenomenon too, that the amount of folate on average that a heterozygous woman was given was 2,800 micrograms, that yet this lady miscarried twice, but she was only ever given 500 micrograms. So you can see the dosages that were used were actually significantly higher. So all were presented with, they were diagnosed with infertility by another practitioner. There were 11 pregnancies. One did not fall pregnant. One miscarried twice, and she was the one that was on that lowest dose of methyl folate. And we did have 10 successful live births. And you can see here that these were the only two that did not fall pregnant. But this one who had had 10 failed IVF and was on the high dose folic acid, she successfully fell pregnant. This one had had one miscarriage, 3 miscarriages, 2 miscarriages, 2 miscarriages, and 5 failed IVF, 5 miscarriages, and they all fell pregnant. So that was a really nice thing to see. And what was another interesting aspect that we saw was that they actually all fell pregnant quite quickly. So there was an initial appointment, and appointment 2 was the first follow-up. And you can see how many were pregnant after that first appointment of being given the methyl folate. It really did happen quite quickly. The only 2 that were outside those parameters were these 2. And they fell pregnant in appointment 4 and 5. Oh, and this one too, appointment 4. So it actually happened quite quickly. They weren't waiting months and months and months and months to fall pregnant. The average time was, between 2 to 4 months for each appointment. So we could say that on average, that was maximum, say, 4 months. So the findings suggest that the practitioners are actually advising their patients to actively avoid folic acid in both fortified foods and in supplements. We know that this 2-step process that folic acid has to go through does create a higher than expected unmetabolized folic acid. So we're just not sure what that means, but there's some research to say that it may have a potential downregulation of the folate binding protein, so it affects 5-methyl tetrahydrofolate. And it may act as a folate antagonist. We don't know for sure, but if that's the case, then this could be really significant. If we look at the supplementation, again, the methyl folate was by far and away the most important methyl folate that was prescribed. And there are studies that are showing us now that it really supports folate status really quickly. Bailey and Aileen did a really good study that looked at, we've all had patients, right, that come in and go, oh, I'm pregnant and I haven't been taking any folate. I haven't been taking any supplements. So they looked at what could get the total folate status up quickly within days, and it was methyl folate, and they used a dose of 7.5 milligrams, and it got the folate up within 3 days to really good acceptable levels. Folic acid did not do that. It took way, way longer to do that. We also know that methyl folate is the main folate in the cord blood, and so allows folate to be transported to the fetus. This is critical, and what we see with these little MTHFR babies is that they are mentally aware, They're very progressed in their thinking and their movement. They are different to other babies that are not what we call our methyl babies. And it's just really interesting to observe that in clinic. Increases mean plasma and red cell folate concentration significantly. And they believe at doses of 800 micrograms or more, it bypasses MTHFR polymorphisms. So that's good for us to know. And you can see there that the dose was actually 2,235 micrograms. That was the average dose prescribed to each one of these patients that successfully fell pregnant. And so I guess basically we just want to say that the practitioners changed the dose, they changed the form, they prescribed much higher doses, and they had a really good success rate. Now, obviously, case series are the lowest level of evidence. We can't extrapolate this to the wider population, but it is interesting to observe this and to be able to hopefully generate a hypothesis that we can test in further research, which I'm hoping we can do that. So thank you for that. I didn't do too badly. Nearly, yeah, it was pretty well spot on time. So I just wanted to say that for those of you that would like to do some mentoring, you would like to find out more about our practitioner training programs, I've put the link there. You can just email me, Carolyn at mthfrgenesupport.com, and we can send you more information if this is an area of interest for you. Because I know a lot of you may not be using genetics or genetic susceptibility, but you may well like to know more about how you can incorporate that into your practice.
Oh, that is so fascinating. Carolyn, it's just brilliant to have you on. You know, this is what IMCO is all about, is having that cutting edge of, you know, the leading research of what's going on in the world from that holistic standpoint. And it's just amazing. I mean, and we feel very privileged that we are the first in the world to hear this new thesis information which you're going to be presenting today. And, you know, how special is that? And before we went live, you and I were talking about connections that we have, that very leading obstetric gynecology connections that we, you know, this is going to change how, you know, a huge aspect of infertility is managed.
Yes,
and
I think it is, and I think it should be.
Big deal what you've done. And so lucky us being the first ones to hear that today. And look, we've got a comment coming in here from somebody watching, Laura, saying that she's familiar with the topic, especially as her daughter is homozygous B677. And but I think for most people it is a very, you know, new piece of information. And so just
Freya has a question. Apologies if I misunderstood, but did you say that those in the study eliminated folic acid from their diet? Yes. Isn't it present in a lot of foods? That's correct. So if let me explain that. So folic acid fortification in foods. So I think in New Zealand, yours isn't mandatory. In Australia, it is mandatory. So all bread flour by law has to be fortified with folic acid. So that means that every piece of bread, everything made with bread flour, pretty well anything in a packet, we have fortification of breakfast cereals. So we have to actively tell our patients, if you see folate on a label, you cannot have that food. So we actively tell them to get rid of the folic acid out of the food. So
just also got a question there. Do you know what the status is for North America and UK on that? Would you have?
Yes, they have mandatory fortification.
Right. Okay.
Yeah. So, and I think that this is part of the issue, and you saw some of those papers, what they suggested is when fortification was first introduced, it was for those poorer communities that they knew were having high incidence of neural tube defects, and they don't have the ability to afford supplements and prenatals. So they said, well, for us to get rid of the neural tube defects, why don't we just fortify foods with folic acid? And that was probably a very good thing to do at the time. But the problem is we've progressed a lot since then. Women know they're supposed to be taking a prenatal. Unfortunately, most of the prenatals have folic acid, but we're getting way more than we were ever meant to through the fortification process. And this is the problem, because at the lower dose, that enzyme DHFR seems to cope with it and progress the folic acid down the pathway. But at a higher dose, it does not. And that's why those women who were taking the high dose folic acid were not falling pregnant. Like 10 miscarriages, like, hello, at some point you've got to say there's something wrong here. We just can't keep doing the same thing over and over again. But leafy green veggies, Freya, let me just go back to the presentation. I want to show you something. If I can exit out of that. If I go back to our folate pathway, I'll show you, I'll go back up here. All right, so when you have folic acid, it comes in at the top here. And unfortunately, the folate receptors preferentially bind to folic acid. So if you are eating leafy green veggies, they actually come in separately. So they come in and get converted to tetrahydrofolate. They come in here. They do not need DHFR to be metabolized to tetrahydrofolate. So folic acid comes in at the top, but our leafy greens come in at the tetrahydrofolate level, but they don't need this enzyme. So, but the problem is, if you've got an MTHFR polymorphism, and let's say you're homozygous, you couldn't physically eat enough leafy green veggies to bypass that 70% downregulation. So it's still really important that they get their methyl folate supplement. Does that make sense? So we just got to make sure we understand the difference. Our natural folates that we get from our leafy greens, they don't need this enzyme. So they come in at this level at the tetrahydrofolate. So that's the main metabolic difference in how that's metabolized.
Fantastic. And what's the, tell me, within general infertility specialists, what's the level of awareness of what you've been talking about? Do most sort of have a bit of an idea, or most have not a clue? Sort of what's the general?
No, unfortunately, I think the problem is if someone's had 5 or 6 miscarriages, they might then say, oh, let's see if you've got the MTHFR polymorphism. They don't do it as a matter of course for everyone that comes in to a fertility clinic, which they actually should. So now that this research has been done, I plan to go in and present this to all the fertility clinics here in Sydney, just so that we can start, because I do work with some really amazing fertility specialists who actually send all her IVF patients to me that have MTHFR polymorphisms. And I still don't know why she refers to me, because literally maybe 1% go back to her. The rest fall pregnant naturally.
She's rapidly losing her business.
But she's just fantastic. You know, she's really good. She's really into it. So I'm going to go and present this research to her group, because I think if they can understand that, you know, people, let's at least start with MTHFR polymorphisms. My gut feel is everybody needs to do it this way, but I can't say that from a research perspective. I've just got to say, right, let's at least look at everybody with an MTHFR polymorphism.
And I know it's not the topic of today, but what's your thoughts with regards to how that impacts once a woman is pregnant and is, given this regular routine folic acid, to prevent spina bifida, etc., neural tube defects, and she has, how do you think it impacts her antenatally?
Oh, hugely, because I think we know that pregnancy is the highest demand for folate that there is. And if we then, I think a lot of them end up with postnatal depression because we're just not supporting. So methylfolate is the only form of folate to get into the brain. And that's what we need for our mental health. So if you've been taking folic acid and you can't convert it because you've got an MTHFR polymorphism, you're way more susceptible to depression. And interesting papers.
That's a fascinating link, isn't it?
Yeah, but there's a really, really interesting papers that have just been released that show that if you give women methylfolate during pregnancy, that actually helps depression. So it is a really good strategy for those that come into pregnancy with depression and you're worried about them. The higher the folate, obviously, the better off. Laura has another question. Do you work with women experience perinatal mood disorders to support their methylation? Absolutely. Yes. So our clinic is not just, so MTHFR Support Australia, we have 5 practitioners. And so we work with everything from anxiety, depression, chronic fatigue, mold disorders, fertility, you name it. It's just such a broad ranging, because that methyl folate that we need affects, as you saw from that chart early on, it affects so many different aspects of our biochemistry. It's not just fertility. So I think anxiety and depression are such a huge, in fact, I've got an anxiety and depression course starting in a few weeks because there is a huge need for it. And I think particularly we're very vulnerable here in Australia. I think the UK and US as well, because of the fortification. I mean, I don't think it's a coincidence that we're seeing a rise in infertility. We're seeing a rise in younger and younger people being affected by anxiety, depression, suicide, etc. And I think this is part of it. It's not the whole story, but I definitely think if we're talking about genetic susceptibility, I think there's a susceptibility problem.
And because most of our viewers tend to be dealing with women once they are pregnant, so we do certainly have some around the world who are involved in preconception, but most are, tend to be birth practitioners. So when they've got somebody coming in to their practice, how do you think how should they be perhaps changing their practice to work with this? I mean, I guess red flags, if that woman has got a history of miscarriage, if that woman has got a history of anxiety or depression. I mean, how easy would it be for birth practitioners to get them tested, and how do they interpret those results? Or how do you think that should change in that, booking visit sort of stage of taking a new client on?
Well, I think if you're seeing someone who is newly pregnant, there's, other than giving them immediately good doses of folate, getting rid of the folic acid.
And what would quote unquote good doses be as far as you're concerned?
I think a minimum of 800 micrograms, but you saw from that study that they're averaging 2,300 micrograms. So I work on the premise, if you've got the C677T, you want them to be somewhere between 2,000 and 5,000 micrograms, and that'll depend on, I just work on how they feel. Some people feel so good on 2,500, some people so good on 4,500. So it really does become then an individual preference. But Freya's asking, how soon before trying for a baby should women be taking methylfolate? Well, at least 3 to 4 months. But if you've got someone, as we said, that has walked into your practice and said, oh my God, I'm now pregnant and I haven't been taking anything, then what the research says is if you gave them a dose of 7,500 micrograms every day for 5 days, well, I think they actually did it for 3 days, their folate would be up. So as a strategy to get it up quickly, that's what you would do. But I would think if you're in the birthing and midwife fields, you need to get in touch with the people that are feeding the people to you and say, by the way, do you know this information? Because your women that are seeing you preconceptionally need this information. So work with your networks to get the word out to say, hey, you need to be, please check all your patients for MTHFR polymorphisms, and please send them the link to, this webinar. Just so we need to work as a group to ensure that every single woman in the world that is thinking about preconception and pregnancy knows this. And I can't possibly do it on my own. So we have to work as a group to just allow people to understand this, because it's really important.
Incredibly fascinating. And, all of these developments that we've got with epigenetics and other things going on, that it's just so exciting and so cutting edge. And, what isn't it amazing what our, by the time our daughters have daughters, there'll just be so much more knowledge on these things.
Well, and I think what's really interesting is that we now know that those people, if I was to fall pregnant today, my children and my children's children are being influenced by what I take preconceptionally.
Yeah.
Now that's pretty amazing. So the health of my child depends on what I take preconceptionally. And they actually were looking at folate
and the health of your
status.
Grandchildren.
I know.
Yeah.
So it is really amazing. And these little babies that are coming in from people that we've helped get pregnant, there is a difference. They are switched on, they're alert, they are learning, they are, they don't have the tantrums, they're more placid, they're easygoing, they're happy. Like, it's amazing to see the effect that we're having just on the babies so far. It's quite amazing. Yeah.
I think a lot of us who have their children and grown up would go, okay, let's just do that all over again. Look, we'll need to wind up any minute now. But look, is there any, if anybody has any other last questions, because we've had a few coming through, which is wonderful, but throw that in right now into the Q&A. And Carolyn, is there anything else that you want to finish with that, you feel like you haven't quite covered?
Not really. I think I would say to everybody online today, don't be scared off by this. I mean, I know a lot of practitioners get a bit nervous about looking at genetic susceptibility because they think it's going to be too hard or complicated or too time consuming, but it's really not. When you're looking at women who are desperately trying to fall pregnant, there's really 3 things that you need to evaluate. What is their ability to make folate? What is their ability to use it? And what is their ability then to go on and have a successful child? So I think it's all about, if someone's susceptible, they've got a genetic downregulation, but environmentally, we have so much that affects that. So stress is one of the number one things that affect the amount of methyls someone has in the system. Now, we've all had an incredibly stressful year for a variety of different reasons. That in itself has created this, I guess, a folate bucket with a big hole. We haven't had enough to tip it up because our stress response has been upregulated pretty much for a whole year for a lot of people. And chronic stress affects your ability to have enough methyls. So imagine if you have if you're homozygous C677T and you've got a 70% downregulation in your ability to create folate, think of it just exactly like that. You've got a bucket of folate, but that bucket has a huge hole. So every time you fill it up, 70% gets lost. So we not only work on filling the bucket up, but we work on plugging the hole. And so if we can do that, and we've proved it again and again and again and again, these women successfully have babies with no problem, no IVF. Their body does what it needs to do. And I think that's what's really exciting.
Oh, it's just been brilliant, Carolyn. Absolutely brilliant. Congratulations again from all of us here at IMCO and everybody watching with the thesis that you've only submitted last night, presenting later today. And that's a big deal. And we're very humbled to have been part of that, completely revolutionary information that you've putting together. So look, thank you everybody for attending today, and tomorrow you will receive an automated email which will also include Carolyn's details, so if you're wanting a copy of her PowerPoint, etc. But otherwise, look, we wish you all a wonderful rest of your week. Thank you for those of you taking the time to be here today live, and those of you who are watching this later on. And thank you very much, Carolyn, once again.
You're most welcome. Thank you, everybody.
Okay. Bye, everybody.